Morning to our esteemed and distinguished guests and this August gathering. For our very first session on approach to a patient with constipation, I would request the chairpersons to join us on stage. Dr. Sanjeev Yadav, sir is a senior physician at Mohak Hospital. Dr. J.K. Singh, sir is a professor in pediatric surgery at Motilal Nehru Medical College. And Dr. Vineet Agarwal, senior physician and ex-director at Railway Hospital, NCR, Prayagraj. Now I would invite our distinguished speaker on stage, Dr. Samir Mohindra, sir.
Good morning, everybody, and we welcome all the guests from the town and from far-off places on this early Sunday morning, and who have taken time off their busy schedule on this Sunday morning. Now, without being any delay, today's first topic is constipation, and I think more than half the Indians, half the patients we see, they have this complaint of constipation. Today, to discuss this topic, we have amongst us Dr. Samir Mohindra. I welcome him to this holy city. Dr. Mohindra has done his DM gastroenterology, and then at present he is professor of gastroenterology at SGPGI Lucknow. He has a special interest in pediatric gastroenterology, and his main interest of area in gastroenterology is the hepatology, and he has to his credit many publications in prestigious national and international journals, and his main interest is in the field of research and education. He has he is an accomplished speaker and giving talks in various national and international conferences. Now I request Dr. Samir Mohindra to please start his deliberations. Thank you.
Thank you, sir. I want to thank Allahabad Medical Association and especially Dr. Rohit Gupta for inviting me for this meeting. When he gave me this topic, my first response was change my topic. Giving a topic, approach of constipation to an endoscopist and pancreatic biliary person. But then when I prepared this talk, then I realized that whichever topic you want to learn, it's always a learning experience. And I learned a lot while preparing this talk. So the talk is approach to a case of chronic constipation. And what I'll be discussing with you is what is constipation, true chronic constipation, what is perceived constipation, what are the common types of constipation, how do we approach a patient with chronic constipation, and how we manage these patients. Because as sir said, it's a significant health problem. Approximately 15 to 20% people, they have constipation in the form of chronic constipation, which is diagnosed as per the latest guidelines. Constipation is a symptom. It's not a disease. And when patients come to us, the symptomatology varies. Patient may say, I have infrequent evacuation, that is less than 3 times a week. They say, I strain a lot. I strain for a prolonged period of time. My type of stool is hard pellet-like. And when I want to defecate in the morning hours or whenever there is a rush, I don't pass stool normally. And I always feel that I have not evacuated completely, and there is some degree of abdominal fullness throughout the day. So why I want to say this is the presentation of chronic constipation can be very variable. And we have to understand what kind of symptoms patients are presenting with. And if you combine all these symptoms, which are so-called symptoms of constipation, approximately 1/3 of population have one or more of these symptoms. Now, if you ask me, what is chronic constipation? Chronic constipation is symptom of difficult, infrequent, incomplete defecation, which is of sufficiently long duration and severe enough to merit help of healthcare services. And if you look at Indian perspective, the standard criteria has been less than 3 bowel movements per week. But surprisingly, more than 90 to 95% Indians pass at least 1 stool a day. So they don't fit into the so-called physician-based criteria of chronic constipation, less than 3 bowel movements per week. stool weight. We Indians generally tend to have a higher stool weight. And studies have shown that approximately 300 to 350 grams per day, the average stool weight of an Indian. And our gut transit is much faster as compared to the Western population. There can be multiple reasons. Many of our vegetarians, our fiber intake is higher. We have a higher prevalence of lactose malabsorption. We have a higher prevalence of small intestinal growth. So these may many factors, but our stool frequency, our stool weight is much different as compared to the West. Now, if you look at the prevalence of chronic constipation, if you look at the Indian data, most of these are small studies, but it is between 12 to 15 or 17%. And if you look at the largest meta-analysis done in the world, it's average of 14%. So we are very similar to the Western population if we take the recent diagnostic criteria of chronic constipation. Now, what are the risk factors for chronic constipation? Chronic risk factors are advancing age, female gender, sedentary lifestyle, lower socioeconomic status, lower level of education, and reduced caloric intake. So these are risk factors for chronic constipation. But there are certain factors in patients of constipation which we should be very alert of. They are known as red flag symptoms or alarm symptoms. For example, if a person is more than 50 years of age, if there is blood in stool, if there is unintended recent weight loss, if there are constitutional symptoms in the form of fever, anorexia, a patient has got anemia, patient present with features of obstruction, if there is abdominal mass which is palpable, if there is family history of GI cancer. So these are alarm symptoms, and if any of these symptoms are present in a patient who presents with constipation, we should be alert. And this is especially very relevant in elderly population who present with recent onset constipation or recent worsening of constipation. So before making a diagnosis of chronic functional constipation, we should rule out an organic cause, and these are the features which point towards an organic cause. Now, if you look at the epidemiology, approximately as per the Rome criteria, 10% of world population has got functional constipation. Now, before going further, we have to understand what is normal defecation. These three diagrams or three cartoons will tell you what is normal defecation. Normal defecation happens when you have increased intra-abdominal pressure, which is voluntary. There is rectal distension, which leads to stimulation of the peristalsia or colonic contraction, which is involuntary. Simultaneously, there is a relaxation of internal and external sphincters, and there is relaxation of the pelvic floor, partly voluntarily when there is relaxation of the puborectalis. So all these three should work in coordination for normal defecation. If any of these are defective, person will have constipation. For example, if there is no stool in rectum, rectum will not contract. If there is a problem with sarcopenia or malnutrition, intra-abdominal pressure is less, then abdominal muscles may not work. If there is problem in the sphincters relaxation, defecation may not happen. If there is a problem with puborectalis muscle, normal stool pattern will be lost. So this is a very coordinated, symmetrical activity involving multiple muscle groups, both voluntary and involuntary, which leads to normal defecation. This is very important to understand. Now this is a video which I want to show. Just a simple cartoon. It basically shows how muscles coordinate. Stool comes, rectal distension of the stimulus which gives the urge, which starts the defecation process. There is simultaneous relaxation of internal and external sphincter and puborectalis, and we pass motion. So this is how normal defecation happens. Now, the question arises, is it a true constipation or a perceived constipation? Now, to differentiate, there are two things. Number one, symptomatology, and number two, stool pattern. If you look at most recent guidelines, how we define true constipation? If a person has these 2 out of these 6 symptoms for the last 3 months over a 6-month period, sensation of straining, sensation of passing hard stool, sensation of incomplete evacuation, sensation of anorectal blockage, if person needs to evacuate manually stool, and if the frequency is less than 3 bowel movement per week. And diarrhea should not be there in more than 25% in absence of laxative use, and the patient doesn't fit into a irritable bowel syndrome constipation type. So this is the symptomatology which has to be there when we want to label a patient as chronic constipation. The second thing to differentiate is the stool form. See, you have to realize that stool form is more important than stool frequency. Now there is a Bristol scale which tells us what is the characteristic of our stool. And it's a very important thing, everybody should have it when we manage constipation. Type 1 and type 2, which are hard stool, lumpy stool, or even in Indian Asian population, now people say even type 3, where sausage-shaped stool with some cracks. So these three suggest constipation. So if there is a true constipation, patient should have a symptomatology as per the Rome criteria, number 1. And number 2, the type of stool should be Bristol type 1, 2 and 3. It's always better to have a stool diary over a 2-week period to get a uniformity about the pattern of stool, because the stool pattern can change on a day-to-day basis. So it's better to have a food diary, ask the patient to have a food diary and see what the stool pattern is. So that's how we differentiate between perceived and chronic constipation. Why this is important is, if patient has got perceived constipation, we don't need to do anything very big. We just need to reassure, ask the patient to take high fiber diet and use the gastrocolic reflux that is going to stool, for defecation maybe 30 minutes after meal, because that is a natural tendency for the body because of the gastrocolic reflux, and most of these patients do well. So there is no need to unnecessarily treat them. Now, broadly, if you look at the pathophysiology, I told you how normal defecation happens. There can be 4 mechanisms how constipation can happen. If there is an obstructive organic pathology in the form of mass, anal fissure, rectocele, they are mechanical obstruction. Then there can be propulsion defect. Defect in the colonic motility, myopathies, neuropathies, or even idiopathy. Anorectal dyssynergia or pelvic floor evacuation disorder, where there is a loss of coordination between the 3 muscles which I mentioned. And subset which does not have any of these, they are labeled as true functional constipation. Approximately 80% of constipation are functional. Now, if you want to classify constipation, it can be primary or secondary. Secondary means there are various causes, metabolic, drugs, and so on. Primary are that there are no organic causes, and it can be irritable bowel syndrome constipation type, you can have functional constipation, and you can have pelvic floor dyssynergia. Rome, a little difference in the classification, but I will not go into it because it's very similar. The opioid-induced constipation is one category which is a little different. So, one important thing is to differentiate IPS constipation type from functional constipation. And how we can differentiate? Pain is a very prominent feature of irritable bowel syndrome constipation type. If patient has got significant pain, it has to be either IBS constipation or an organic pathology. And what is the diagnostic criteria for IBS constipation? Recurrent abdominal pain at least once a week with change in stool frequency, change in stool pattern, or pain related to defecation. So if this diagnostic criteria is fair, then IBS constipation diagnosis is made. And when a patient comes to us with constipation, how we approach these patients? We need to look at the symptoms of constipation, which I told you: hard stool, less than 3 bowel movements, straining, manual evacuation, feeling of incomplete evacuation, feeling of fullness, and so on. And there are certain symptoms which are very typical of fecal evacuation disorders, which we need to look at. If person strains for a prolonged period of time, excessive straining, if there is perineal fullness, patient feels that there is fullness there, if patient needs to manually evacuate, it suggests fecal evacuation disorder. It is not diagnostic, but it suggests. Now, we look at obstetric history, we look at surgical history, we look at type of diet, we look at amount of fluid, we look at lifestyle, smoking, alcohol, we look at the degree of exercise or physical activity a person does, drug intake, important drugs being antidepressant, tricyclic, calcium channel blocker, and so on. But the most important symptom for me is ask for a history of urge to defecate. Now, if there is a persistent urge, it means that the rectum is full and the person is not able to pass. It is suggestive of fecal evacuation disorder. If patient does not have any urge, it means the rectum is empty and it's a slow transit constipation. So that's how you can differ. If there is persistent urge, the rectum is full, fecal evacuation. Low urge, it is a slow transit. Okay, and if urge is present, when the person goes, then it's a normal transit. So it's a marker of which type of functional constipation we are dealing with. red alarm, flag signs, I've already told you, we need to look at these and rule out organic cause. Examination, we look at general examination, pallor, we look at malnutrition, we look at any abdominal mass being palpable. But for me, the most important part of examination is rectal examination. It's very important, and any patient of constipation, irrespective of age, sex, type of symptoms associated with constipation, we need to do a rectal examination. And what we need to look at, we look at index to resting anal pressure, we need to look at squeeze pressure, we need to look at perineal descent. All these things are very important, and a lot of diagnosis is missed if we don't do a good digital rectal examination. It's very important. Now, another important aspect is, conventionally we say we do a step-up approach for management of constipation. I differ a little bit. It depends upon the severity of constipation. If a person has got severe symptoms of constipation, we should have a step-down approach. And if the symptoms are milder, then we can always go with a step-up approach, which we conventionally do. It depends upon the severity of symptoms. I told you, rectal examination is very important, what we look at. In addition, we can look at findings like rectal mass, anal fissure, and so on. So, digital rectal examination is a very important part of examination. Now, I want to talk about this synergic defecation. Why I want to talk about it? Because this is one group which is often missed, and they are treatable. So, I need to show you this. See, stool comes in the rectum distends, sphincter should relax, pure rectalis should relax. But what is happening? It's a paradoxical rise in anal sphincter pressure. Rectum is trying to push the stool down, but the sphincters are not opening up. So there is a dyssynergy or incoordination. And this group of patients are often missed, and they are very much responsive to treatment if adequately timely picked up. There are certain symptoms of dissonant defecation which we need to be careful about. Prolonged straining, excessive straining, if there is feeling of finger evacuation, feeling of something obstructing lower down, and heaviness in the perineum. What are the diagnostic criteria? You have functional constipation with either two of the following: anorectal manometry, balloon evacuation test, and defecography. Any two out of three positive, we make a diagnosis of dyssynergic defecation. And the symptoms have to be there for at least 3 consecutive months over a period of 6 months. So, when we approach these patients of constipation, how we investigate them? We do the routine test to rule out the secondary causes. We do a full colonoscopy if there are alarm symptoms. Then we do it. There are certain physiological tests which are very important for managing functional constipation, mainly colonic transit, defecography, balloon expulsion test, and anorectal manometry. What we have to realize is, when we do these tests, patient should be off laxatives. It's very important because it can interfere with our interpretation. Coming to the test for colonic constipation, colonic transit time is a very simple test. We give radio-opaque markers and then see how many pass at 36 hours and 60 hours. And if they are 14 and 30, 30 and 40, 36 and 14 at 36 hours and 60 hours, it suggests that there is a slow transit. And you also look at the pattern where the pellets are stuck. If the pellets are stuck in the left half, lower half, it means that dyssynergia, all are in the rectosigmoid. But if they are uniformly spread out and not coming out, it's a slow transit constipation. It's a very useful test, and it can be done easily. Rectal manometry, very important test for functional constipation, where we put a transducer and measure the pressure. We measure the baseline pressure, we look at the squeeze pressure, and it is very important that we also look at the rectal sensation. When we inflate the balloon, and if the sensation does not happen, it means there is a rectal hyposensitivity, which again suggests a kind of a functional constipation. This is a catheter which we use. We have 10 sensors. There is a balloon which inflates, and the patient feels the sensation, and patient defecates. We have various types of dyssynergias. I will not go into detail, but what we have to realize is, what we look at is the rectal contraction and sphincter relaxation. Rectum may contract too much, sphincter may not relax. Rectum contracts, sphincter do not relax. Rectum does not contract too much, and sphincter doesn't relax. So there is a combination, but type 1 is the most common, where you have an increased rectal contraction and a paradoxical rise in the sphincter contraction. This is the commonest type of dyssynergia which we see. Balloon expulsion test, a very easy test to look at the fecal evacuation disorder. We inflate the balloon, 50 ml water, and ask the patient to expel it. If the patient is not able to expel within 2 minutes, it's abnormal, it's a fecal evacuation disorder. Defecography, useful test, but we generally do it if we don't get information from anorectal manometry and balloon evacuation test. It gives you some idea about the anatomy, what is the anorectal angle, how much is the perineal descent, and we generally we can use either MR or barium, whichever is available. This is how it looks like. There has to be a straightening of the anorectal angle when the person strains, and there should not be perineal descent more than 4 centimeter or less than 1 centimeter, so as to suggest fecal evacuation disorder. EMG, we generally don't use it for myopathic and neuropathic disorders. Colonic transit, we don't have, we look at GI transit, basically colonic transit. Now coming to the management. Management can be non-pharmacological, pharmacological, and then specific treatment for dyssynergias in the form of biofeedbacks, and of course in a small subset we need to resort to surgery. Non-pharmacological treatment is very important, and most of our cases mild. We give, what we do is we deal with diet, we change the habits and associated issues. Now how we change the diet? We ask the person to take excess of fluid in the form of 2.5 to 3 liters. We need to increase the fiber intake. Indians, most of the time, do not have inadequate fiber intake. Our target is 25 to 30 grams of fiber per day. Most studies have shown that most of our Indians, they eat that much of fiber. The fiber supplementation generally doesn't work in our product, but if the person is taking insufficient fibers, we can increase it, of course, and we should use more of a soluble fibers. Very important toilet training modification. What happens is, when a person sits in a squatting position, the anorectal angle becomes conducive for natural defecation. So we are fortunate that most of our Indian toilets are like that, but Western population, the angle is not straightened and there is difficulty in defecation. But if the person is using Western toilet, we can request him to use a Indian toilet, and if not possible, they can elevate their legs while sitting, so that angle is more conducive for natural defecation. Coming to drugs, there is a long list of drugs. I would only discuss few drugs. First line drugs are bulking laxatives, stimulant laxatives, osmotic laxatives, stool softeners, and lubricants. And second line, now we have got newer drugs which are coming off, and basically they look at the iron transport regulators across the bowel. Most commonly used bulking agents are psyllium, polyethylene and magnesium hydroxide. They are all bulk agents with a little bit of osmotic action. Then we have stimulant laxative in the form of bisaccharide, sodium picosulfate, senna, and castor oil. Now the newer drugs are in the form of secretagogue, lubiprostone, enteroparetic, nucleopride, and antibiotic rifaximin. So we start with bulk laxatives in the form of psyllium or isobor. And it's always better to start with a low dose and step up. We start with 5 to 10 grams per day and we go up to 25 to 30 grams per day. But I told you, most of us as Indians have got almost normal intake of fiber. But if there is deficiency, we can always add on. Number two, the drug is the osmotic laxative. What we commonly use is magnesium hydroxide. We use lactylol or magnesium hydroxide, milk of magnesia, and lactulose and lactylol. And again the same criteria, we step up the dose. We start with the lower dose, and depending upon the tolerance and the response, we step up. Stimulant laxatives are less commonly used, but if the patient does not respond to bulking agents or osmotic laxatives, then we go to the stimulant laxatives. Now coming to the newer drugs. Newer drugs, there's a long list, but I have only mentioned these four. Lubiprostone is an intestinal secretagogue. It basically works at the chloride channel. It opens up the chloride 2 channel, and what happens is a lot of chloride comes up and the volume in the bowel increases. Very safe drug. We use between 8 to 24 gram. 24 gram is used in chronic constipation. In IBS constipation, 8 microgram. The main side effect is diarrhea, but it is most of the time self-limiting. Linaclotide, again an intestinal secretagogue. It acts on the CFTR, again opens up the chloride channel, the same mechanism. channels are different. Those are 145 to 290. 290 is used in constipation, 145 microgram per day in IBS constipation. Again, the main side effect is diarrhea. Most of these drugs, the side effects is diarrhea and incontinence. The newer drug is precanatide. It is an intestinal secretagogue. It basically stimulates the CFTR, opens up the CFTR channels, and it leads to chloride secretion. Dose is 3 milligram. Side effects are mainly diarrhea and a little bit of headache. The newest kid on the block is eloxabat. Eloxabat is an ileal bile acid transport regulator inhibitor. So what happens? Increased bile salts come into the colon, and it leads to increased volume, increased transit, increased motility, and rapid evacuation. Dose is 10 milligram post breakfast. Main symptom again, side effects are diarrhea, abdominal pain, and flatulence. There is another drug which is tenapavir. It's basically inhibitor of sodium hydrogen regulator, where what happens, excess sodium comes in and water gets into the lumen and it makes the bowel distended, and it leads to better evacuation. There are other techniques not easily available. Transcutaneous electric nerve stimulation, where we stimulate the sacral nerve or the tibial nerve, and basically interstitial cells of Cahal are stimulated, and it stimulates the motility of the bowel. It's a useful technique but not available everywhere. Vibrating capsule, we give capsule for 5 days in a week, and then it acts on the motility and stimulates bowel. There have been few studies but not very commonly used, but in few studies it has worked. Biofeedback is a very important aspect of management of chronic constipation, and this is basically for dyssynergia, that is pelvic evacuation disorder. Here what we try to train the person through the visual and auditory stimuli. We do an electromanometry, we ask the patient to see on the screen what is happening. And what happens is, when the person strains, the rectum should contract, abdominal muscles should contract, and the sphincter should relax, and the pelvic floor should relax. So there's a dyssynergy. We ask the patient to look at the screen where there are pressure tracing, and we ask the person and make the person understand that what is going wrong. So when the person is contracting the rectal muscles, the sphincter should relax, and the pubic trachea should relax. So we show on the screen that what the person is doing wrong, so that the person learns with a visual or auditory stimulus that stimulate which muscle, relax which muscle. It's a kind of a training of how to do defecation, and it's a very useful technique if done properly. It's basically retraining the person for defecation. That's all. Indications are basically dyssynergic patients and associated issues like rectocele, intussusception, and so on, but basically for defecation dyssynergia. That's how we do it. Now, when to do surgery? Surgery is indicated in a minority of patients, and when the symptoms are chronic, disabling, and not responding to non-pharmacological therapy, pharmacological therapy, and so on. So a very small subset of patients may need surgery, and what we have to realize, before subjecting these patients for surgery, we have to look at three things. Patient should not have significant chronic pain, should not have chronic or severe depression, and should not have dyssynergia, because these patients don't respond to surgery. So if any of these are not there, our medical therapy, pharma as well as non-pharma therapy is not working, then we can go ahead and ask the patient to help us, ask the surgeon to help us out. So ladies and gentlemen, I would end by saying that if patient has got chronic constipation, we need to rule out secondary causes. We need to have a detailed history and examination looking at person profile, person defecation practices, person social milieu, and associated comorbidities. Very important to look at, because many of these lead to correction. Look at alarm symptoms. If they are present, we go to this side. If alarm symptoms are not there, we go to symptomatic treatment, laxatives, softeners, and newer drugs which have come into picture. And if the response is good, fine. If the response is not good, then we need to talk to the patient and refer the patient to a tertiary center and maybe take the help of psychologists, surgeon, and so on. Thank you.
Mohindra, for exclusive talk. You have covered the topic, the very common topic, useful for the physicians. And now the question our speakers. If anybody wants to ask questions, please welcome.
We have the mic here, please, we can have the questions here.
Does alcohol cause constipation or diarrhea?
But
Alcohol, effect of alcohol on constipation.
it can cause either, but most time it is a irritated, it causes diarrhea more often. I mean, alcoholic sugars have been used, but not alcohol.
Bitonin at one time used to contain alcohol, so that sort of liquid which can be given to the patients. Am I clear? In our old times, bitonin syrup used to have alcohol in it. So it was being prescribed as a sort of a palliative therapy for appetite. But can this be used for constipation as well?
Alcoholic sugars like sorbitol or mannitol, have been used like LOL, but alcohol as such has not been used. But one surprising thing is none of the guidelines say that you should stop smoking and stop alcohol. So maybe it works.
So just a comment, I think everybody should have a Bristol stool chart. You can download it from the web, and sometimes the patient is very confused what type of stool. If you have a Bristol score chart, then he can tell you this is the one. And if it is 1, 2, 3, it is constipation, and 5, 6 means it's diarrhea. So that is one thing. The other thing which Samir alluded to is the digital rectal examination. I think every one of us has burned his fingers of not doing a rectal examination or proctoscopy in a patient who has constipation or even bleeding per rectum. Everybody should at least have a proctoscopic examination or a sigmoidoscopy. Any age plus rectal examination is a must. Only 2 comments. Thank you.
My side, what is best medicine for pregnancy-induced constipation besides diet and exercise? Medications. Best medication.
So, newer drugs, intestinal secretagogues, are not safe in pregnancy. So, butyranide, dubiprostone are not to be given in pregnancy. So, basically, we look at the laxative, bulking laxative, osmotic laxative, and to a certain extent, stimulant laxatives. We can give that. But none of these drugs have enough data to say that they are safe. Lubiprostone is not to be given in pregnancy. So indications are IBS constipation, chronic constipation, and constipation in women, but not pregnant women. So there's not enough data to say that these drugs can be safely given. I'm talking about the secret of
Which is the best safest? I used to give isabgol kind of thing.
Isabgol. See, we should start, depends on the severity of symptom. If severity is mild or moderate, we start with bulking agents, we give osmotic laxative, we give stimulant laxative. For example, isabgol, we start with bulk agent. See, the problem with isabgol is, I'll tell you what, it depends upon the profile of a patient. Most of us as Indians have reasonably good fiber intake in the diet. Okay, so I think most of us will have 20-25 grams. Going beyond doesn't help. So if the patient is not of a youngster, not eating fiber, then adding bulking agent is fine. But if the person already having 25-30 grams, if you give bulking laxative, it will make his symptoms worse. Because if you are giving fermentable fiber, it will lead to gas, bloating, patient will become worse. So if the fiber intake is inadequate, start with bulking laxative. But if fiber intake is adequate, then you should go to osmotic laxative. Osmotic laxative means lactose, magnesium hydroxide, lactylol, and then if it doesn't work, then you can go to a combination of osmotic and stimulant polyethylene glycol, which is a stronger one, but it's a very useful one. So, I didn't mention Procainamide, actually will take time. Procainamide is a very useful drug and very minimal side effect. The main side effect is maybe abdominal pain, diarrhea and headache. It's a very 5-HT4 agonist. It's a very useful drug, but the problem is you have to be very careful with patients with renal failure. And the pregnancy we don't have enough data to say that you can terminally safely get, but it's a very useful drug. which can be given if these don't work. So it has to be, but then again I tell you, if a person presents with severe symptom, I will not go by step-up approach. I will go by step-down. I will give multiple drugs which have different mechanisms. So I would give a laxative, I will give glucalopride, and the patient can afford, I can even give pliquenatide.
Samir,
If the symptoms are better.
please be brief.
We have two
Brief
questions
question.
of how important the constipation is at the start of the morning.
In IBS patients, most of the patients are complaining of incomplete lubrication. Even they have purchasing stools 4 or 5 times in a day, and not very hard. It's just cold, I think, 3-4. So, इनको आप किस कैटेगरी में रखेंगे, कॉन्स्टिपेशन में रखेंगे, डायरिया में?
जैसे मैंने बोला,
What is the-
so फंक्शनल कॉन्स्टिपेशन 5-6 चीजें हैं. इनकम्प्लीट इवैक्यूएशन है, फ्रीक्वेंसी कितनी है, स्ट्रेनिंग है कि नहीं है, फीलिंग ऑफ इनकम्प्लीट इवैक्यूएशन है, उन चारों में से कोई भी 2 हो जाए. फीलिंग ऑफ इनकम्प्लीट इवैक्यूएशन के साथ कोई ना कोई सिम्टम और हुआ उन 6 में से, तो दे विल बी क्वालिफाइंग एज फंक्शनल कॉन्स्टिपेशन, है ना. और अगर आप ब्रिस्टल स्कोर है 1, 2, 3 में, एक्चुअली प्रॉब्लम ये है कि जो वेस्टर्न डेटा है वो कहता है टाइप 1 एंड टाइप 2 आर एसोसिएटेड विद कॉन्स्टिपेशन. इंडियन डेटा एंड कोरियन स्टडीज हैव शोन even type 3, which are sausage shaped, not very hard, they are also a type of constipation stools. So अगर हम उसको करेंगे ना, तो आपके पेशेंट को जरूर उसी तरह का स्टूल होगा. 1, 2, 3. We should have a Bristol 3 also kept in mind, and we should take it as a part of a constipation stool. I mean, person with constipation has a stool.
What should be the treatment modality of such patients?
Pardon?
What is the treatment modality of such patients?
See, feeling of incomplete evacuation means a symptom of constipation. I told you the big thing. Feeling of incomplete evacuation means पेट खुल के साफ नहीं होता. So what is happening is, physiologically, a little bit of stool comes in the rectum, which is a stimulus for urge. Patient gets an urge, patient passes motion. Then what happens, after some time, the similar thing happens, a small amount of stool comes, then gets an urge, and he or she passes motion. So it's basically a feeling of incomplete evacuation is a manifestation of constipation, because there is no diarrhea. If you look at the Bristol score, or Bristol fecal scale, the pattern of stool is consistent with constipation. And frequency is not important. What is important is the symptomatology, which I mentioned 5 symptoms, along with the form of stool, which decides. आपको तो इंडियन डेटा ने बताया कि जो IBS कॉन्स्टिपेशन है और IBS डायरिया है, इंडियन स्टेट में आया कि उसका नंबर ऑफ स्टूल बराबर होते हैं. वो भी 4 बार जाते हैं, वो भी 4 बार जाते हैं, बिकॉज दे गेट एन अर्ज रिपीटेडली, और फ्रीक्वेंसी सेम रहती है. तो फ्रीक्वेंसी इज नॉट अ वेरी गुड क्राइटेरिया अलोन to differentiate constipation from diarrhea. We should look at multiple other things.
Thank you, Dr. Samir, for a wonderful session, and I compliment you to finish in the time. Sorry?
Good morning, sir.
Okay.
Sir, my one question was, there are many laxatives in the market now which are coming as combination laxatives. Like they have Isabgula and they have polyethylene glycol. So what is your take on any advantage of using a combination laxative versus a single molecule laxative?
I mean, this is only India specific way you are able to get such combinations. But the strategy should be, you start with single agent. If it doesn't work, you step up. But now the most recent approach is that you target multiple mechanisms. For example, if you are giving a bulking agent, then you may not give a laxative, you may add a drug like glucalopride, which acts on a different mechanism. So what people are looking at is looking at pathophysiology from multiple angles and trying to address different mechanisms. Using it as a combination, I'm not sure because data is not there, but I think it should work because it is targeting different mechanisms. But my problem is when you mix 2 molecules, how much effective they will be on their own is a problem. It's better to give separately. You give one bulking agent, you give glucalopride separately. There's no problem.
Okay, thank you. Now I think we wrap up the session. Please give Dr. Samir a big hand of applause. Thank you so much.
That was indeed an enlightening and a very interactive session. Now I request our President AMA, Dr. Kamal Singh sir, and Organizing Secretary, Dr. Rohit Gupta sir, to please join us on stage. to felicitate our speaker and chairperson. Hello.